kind of completely over blue. I've worked on HIV and AIDS issues for over 10 years, particularly on access to medicines, but increasingly, I grew up just to the north of the border. Increasingly, when I was working overseas, I was seeing back home in the NHS and in Ireland and other European countries, the challenge of high prices weren't just issues for the developing world anymore. And frankly, I didn't feel that we were doing a good enough job of looking straight at the core drivers of that problem to find the solutions. So a couple of years ago I set up Just Treatment, which is aiming to have a patient-led effort to reform the pharmaceutical industry to tackle the challenge of high prices. So I'm going to take we've heard a lot from Michael about the problems, and we've heard from Baz about the solutions. I'm going to cover some of that, but in a slightly sideways look at some of those issues, and then think a little bit about how we get there. So at this stage, this is just, you can see there, that's a map of the world, and highlighted on that map is in red is every country that doesn't have a problem with access to medicines, all right? So yeah, it's a bit of an indicator that this is a problem for everybody. Ireland is not an outlier. The pharmaceutical industry loves to tell people that Ireland is this real kind of problem, and everybody else in the world's got it sorted, and why don't you guys just sort your stuff out and get access to this price? They tell the NHS the same thing. It happens all the time. But the reality is that if you go to the US, this is the mother of Alex Smith. She's carrying a vial of her son's ashes. He died a short time after dropping off his parents' insurance plan because he couldn't afford his insulin bills. This is Tebeka Daki. She was a South African health activist. She died without access to Herceptin, breast cancer drug. It metastasized and spread, and she died without access after a year of fighting for access to medicine. After a life of fighting for access to medicines for her fellow South Africans. And this is one example from Denmark. So it's not like even the kind of the rich Northern European countries don't have a problem with this anymore. This is the example of the first rejection of a medicine in Denmark a couple of years ago, an indicator that really this problem is growing and spreading and becoming unsustainable, as Michael said, for every country. So across Europe we're seeing this, and we talked about the Benelux initiative, which Ireland is involved in. We also have the Valletta initiative, and we have efforts from the Italian government, from the Portuguese and from the Austrian government, as well as the really impressive work that the Dutch government have been doing on this. This is a problem everybody is facing, and we need to face up to that reality. I'm working in the UK, I live in Bristol now. These are some of the people and patients that we've been working with through Just Treatment. Carolyn, sadly, passed away 2 years ago. She had to pay out of pocket for access to Kadcyla, a breast cancer treatment that her oncologist recommended because it wasn't affordable to the NHS at the time. Claire was a Hep C patient, and she was denied access to the cephalosporin-based treatment for Hep C because, again, the price was too high and the NHS was rationing treatment. She had to go through actually the very difficult older treatments, which have very bad side effects and aren't as effective, and they didn't work. And she's had long-term health and mental health challenges as a consequence of that before she finally got treated. And then lastly, there's Lewis, who is one of my personal heroes. He's involved, along with his mother and his family, in our campaign around access to Orkambi at the moment, and I'll come back to that later on. So this is an issue for, we talk about the wealth of Ireland, but this is an issue for every wealthy country in the world. So, this is a slide, this GIF gets crazy, but it goes multicolored, there we go. Anyway, what's the solution? We know there's a problem. I think we shouldn't we can't spend too much time picking apart all of the problems. I haven't even touched on many of the ones that we've talked about as well, around the lack of quality of evidence, the lack of impressive, important new drugs. But I think it's important for us to start talking about what we're going to do about it. What are the solutions? And I'm going to start, as I said, this is not like going to be a complete bullet point list of here's our policy responses, but let's have a think about some of the things that could work and the things that won't work. First up, controversial, spending more money on medicines isn't going to solve the problem. If we increase the budget for drugs in Ireland or the UK or any other European country, The pharmaceutical industry hold monopolies, and they will respond by putting the prices of their drugs up further. It's really basic economics. We cannot throw money at this problem. You know, regardless of the size of the health budget, you're going to have challenges around getting it. So we really need to think more deeply about what the solutions are to this, beyond just demanding more money be spent on medicines. And that's particularly true when we contrast some of the opportunity cost of spending more money on medicines. And that's true within our health system, but it's broadly true right the way across the board. Anybody in Ireland will be able to tell you about the number of other social and economic justice issues that exist out there. Should we really be solving the problem by putting more money into the pockets of the pharmaceutical industry? I don't think we should. Particularly when we look at it, we've already got $1 trillion spend on medicines globally every year. And in return, in terms of investment in innovation, we only get from the pharmaceutical industry about 150 billion per year. So we spend $1 trillion to get 150 billion's worth of innovation. That's not a great return. So we need to think more clearly about what the problems are. We talked a bit about value, and Michael talked about this. Value-based pricing is not going to solve this problem either. This is an increasingly fashionable way that the pharmaceutical industry like to talk about how we should think about the price of a medicine. This is an effort to shift us away from the ground that they don't like engaging on, which is the cost of R&D or the cost of production of medicines, away to something else that seems more legitimate, which is like, what are the value that society and patients can get from the medicine that they're paying for. Jack Scannell, who's an economist and healthcare venture capitalist and investor, said that this is unacceptable. This is like applying luxury handbag marketing and pricing strategies to essential goods. It's just not justifiable, and the WHO have come out strongly against it as well. If you imagine other parts of the healthcare system applying this kind of pricing strategy, could you imagine if our midwives started pricing their care and interventions based on the value of that to the rest of the healthcare system and to the rest of the economy? It just wouldn't work. I'll also say, controversially, potentially for some, cutting red tape isn't going to solve this problem as well. Our drug prices aren't high because of the regulatory burden that are placed on the pharmaceutical industry. There may be some scope for some streamlining or for some more efficiency in the system, but it's not going to solve the problem. And we need to be really careful about some of the negative consequences of reducing the regulatory burden, because we already see that some of the drugs, or many of the drugs we're getting, aren't good enough and have negative side effects for patients. And we've seen, I don't know if people saw, but Panorama did a big investigation around medical devices and implants a few months ago. And it really shows that if we don't have an effective regulatory system, you can have real negative consequences for patients, and we should be very wary of that risk. And I'll also say again, maybe this is slightly controversial as well, we're not going to fix this problem if we only campaign for access to individual drugs. We need to be thinking systemically, and that's as much patients' responsibility, as difficult as it can be at times. To do that, we need to think systemically. So that's what I think isn't going to work. Here's what is going to work. We have to get rid of TINA. TINA stands for There Is No Alternative. This idea that the system we've got at the moment is the only way of doing business that can never change is not acceptable, and it's not based on reality. Baz's team have done an amazing job of coming up with a whole raft of policy alternatives that we could be implementing. The WHO has done the same thing. The Lancet have done the same thing. We've done a report with the economist Mariana Mazzucato. She's an innovation economist. We are not short of effective alternatives, and we've seen them work in other areas, and there is a willing and a willful effort by the industry and by others to shut down the idea that there are other ways of doing business. Patents are one means of incentivizing innovation. There are many more others, and they don't need to involve rationing of medicines or denial of patients access to treatments that can keep them alive. And Jamie Love, I think, after the break, is going to talk in much more detail about some of those alternatives. I think what will work as well is recognising that the core driver of high prices are monopolies. And so long as we understand that we're trying to tackle monopolies and the high prices that come with them, then we're likely to come up with solutions. They're going to fix the problem. Baz talked about more power to the buyer. That's really important. So what can we do to increase the power of the buyer and reduce the power of the monopolist? Benelux, Ireland is involved in, is one example of that. I think I mentioned Mariana. This is one of her first books, which is looking at basically scrapping this idea of the myth that all the innovation comes from the private sector. She's looking right the way across the board, from like Google and high tech and Apple stuff to defence and everything in between. And the reality is that the public sector does a lot of the really groundbreaking, important innovation. It finances a lot of it, and that's true as much in the pharmaceutical industry as it is anywhere else. So we need to think about the importance of the contribution of the public sector and recognise that in the solutions that we come up with. And then we also need to accept this is not about good ideas and bad ideas. Lots of this is about power. This is about a huge part of this is about the huge influence of the pharmaceutical industry over our political processes. This is an example. This is 2018. This is from Congress. It's slightly more transparent in the US around lobby spend. But year on year, the pharmaceutical industry outspends every other industrial sector in its effort to influence politicians on the political process. It's very similar at a European level as well. I don't have the data for Ireland. But year on year, somebody once told me that actually they were outspent one year by the financial sector, and that was the year after the financial crisis, when the financial industry was particularly motivated to respond to political efforts to regulate and control them. So we have to deal with this reality. And so actually, part of what we need to be thinking about and how we come up with solutions is how do we deal with the power of the industry over our political processes, and how do we build the political power to challenge that wealth and spending. And I think I would argue one of the things that's going to work to do that is patient solidarity. High prices are affecting all kinds of diseases, whether it's cancer or cystic fibrosis or hepatitis C or any of the rare diseases like SMA and others that we hear talked about regularly. And it's happening in all parts of the world. Really the industry relies in part upon dividing and conquering in how they win approval for the medicines that they're at the prices that they're demanding. We need to think better as patient groups of how we can collectively press for interventions that help every single patient group and not just one individual drug or for one individual disease. So that solidarity, I think, is really, really important. And we need to think about investing in campaigns that make it easier and better for the next patient that wants to fight for access to their drug, not actually reducing the amount of cake that's left on the table. So I would argue that if your campaign isn't thinking about whether or not it makes life better for the next patient with an access challenge, then you may be utilising the wrong strategy. One example of that is, I talked earlier on about Lewis, but we're campaigning the UK around access to Orkambi. Really similar situation to what played out in Ireland, a standoff between Vertex, who are charging a just unconscionable, an unjustifiably high price, with a health system that didn't think it was justified and couldn't afford it. But we're not attacking the health system and the NHS for saying no. But we're also not saying that, well, let's throw our hands up. This price is too high, it's not cost effective. Well, what can you do? That's not a fair outcome. And as Kay was saying, it's not good enough for our governments to just sit back and accept that if the price is too high, we're going to wait until the price drops. That's not a good strategy. We've got powers within our laws and within our legal system, within our governments, to do something about high prices. And so our campaign for a Plan B and Orkambi is demanding that the UK government steps up in the light of the fact that 3 years of talks have ended in failure and prioritise the health of cystic fibrosis patients over the bottom line of Vertex. And they can do that through a number of means, but we're calling for the use of a Crown use licence. And that's a kind of government use or compulsory use licence, which is enshrined in international law and in UK law and in Irish law, that allows a patent to be suspended and grant another manufacturer the right to produce it, despite Vertex holding the patent. We estimate that we could save almost $4 billion over 10 years for the NHS if they pursued this outcome, because the price could drop from £104,000 per patient per year to less than £5,000 per patient per year if it was procured from a generic manufacturer. Why aren't we doing that? Why are we now not prioritising the well-being of patients over Vertex's commercial interests? I kind of said I wasn't going to go into like a shopping list of other interventions, but I wanted to mention the People's Prescription, which we produced in collaboration with the Institute for Innovation and Public Purpose at UCL in London, which is led by Mariana Mazzucato. We did it in collaboration with Global Justice Now and Stop AIDS, two other organisations. And that runs through some short-term interventions that need to be taken, and it really kind of echoes many of the recommendations that Baz produced. There are things that we can be doing: volume-based, improved procurement, price transparency, and I think Dimitri is going to speak more about the importance of transparency later. Stricter patentability criteria, like let's only give out patents whenever they're actually deserved. Like Michael talked a lot about what is innovation. Oh wow, I've got 5 minutes left. 2 minutes or 5 minutes. So yeah, we only give out patents. We only give out patents to medicines that are truly innovative, that truly give a therapeutic benefit. If we did that, as some countries in the world do, you compare the number of patents on drugs, and the same drug, if you compare the number of patents that are granted in the US to the number that are granted in Europe, to the numbers that are granted in places like India, where they've written their patent laws specifically to safeguard public health and to prioritise genuine innovation, you'll see the difference. And the consequences of that are the length of the monopolies that those companies have. Yeah, and I'd also say, I'm going to skip the last bit just to kind of get to the end. These are slightly more transformative things. This is like the stuff that we can do in the long term. And Jamie's going to speak about this as well. But in other areas of the economy and society, we set missions that tailor and drive innovation in different ways, which much more government control. At the minute, decision making on what drug and which area of research gets undertaken, a lot of that is in the hands of the pharmaceutical industry. And they make their decisions not based on public health outcome or need, but based on potential profitability of the compound or the medicine. And so they're basically setting the mission for what kind of medicines that we get. And that has, sometimes those two interests are aligned, profits and public health interest, but a lot of the time they're not. So we need to take greater control, to set missions, to guide the innovation process. And Jamie will speak more about the concept of linkage. We are spending a lot of money already funding R&D, and we are very bad at holding the companies that utilise that innovation to account for how it's used. So we need to place greater conditions on public funding, and we need to explore governance reform of industry. Why do we allow the execs of pharmaceutical companies to be reimbursed based on their share price instead of the actual therapeutic impact of the medicines they produce? Why aren't we publicly paying for the later stage clinical trials? Why don't we have democratically owned, not-for-profit generic manufacturers? There's lots of things that we could be doing. And I think we need to do it in a way that respects patients and has them at the heart of what we're doing. And that's what we're trying to do with Just Treatment. This is Lewis and his mum Christina, who are two totally amazing people. They've basically decided that whilst Lewis needs access to Orkambi, she also recognises, and he also recognises, that there are other patients that need access to. That they love the NHS, that they, as flawed as it is and as flawed as NICE are, and they've got issues with it, ultimately responsibility for this problem lies not in the hands of the NHS, but in the hands of the pharmaceutical industry. And they're using their story and their position to try and fight for the kinds of systemic changes that will make life better for the next Louis and for the next Christina. And this is really important because this is Julie. Julie was one of the patient leaders that we work with. We've got a group of about nearly up to 20 now. Julie was a tireless advocate for access to cancer treatment. She died at the start of this year. She had breast cancer, and it metastasized to her brain, and unfortunately, in the end, there was nothing more they could do for her. But through her entire time, she fought really hard, not just for access to breast cancer drugs, but also for access to cystic fibrosis drugs and for access to hepatitis C drugs. And I think we need to remember people like Julie and ensure that what we're doing is about fighting for everybody and ensuring that the importance of each individual patient's life is reflected in the decisions of our government. And it boils down to the kind of world that we want to live in. Thanks very much. That's the end. You can see, if you want to follow us on Twitter, or if you go onto our website, you'll be able to hunt around in the update section. You can get a copy of the People's Prescription Report in there. Thanks for your time. I'm Diarmaid McDonald. I work for Just Treatment in the UK, which is a patient-led organisation campaigning for fair access to medicines on the NHS, and particularly fighting to take on the unjustified high prices of the pharmaceutical industry. And I've been working on access to medicines issues for over 10 years, particularly looking at access to medicines in the developing world, in the global south, for HIV, and trying to fight for a fair system for everybody to get equitable access to drugs. I'd say the main take-home message from today, which was really fantastic, loads of great ideas, is that, the problem isn't that we don't know how to fix this problem. Everybody agrees it's an issue. Everybody sees it in their day-to-day life, whether you're a doctor or a patient, or whether you're working for the Department of Health or the National Health Service or the HSE. The reality is that this is an issue. But we know how to fix it. There are loads of brilliant ideas around how we tackle high prices and how we get better innovation on medicines. The problem we've actually got is political will. Like, how do we build the power to ensure that governments prioritise the interests of patients and the healthcare system over the interests of the pharmaceutical industry? Because right now, they're siding with drug companies, and that has to change. I love this event. This is great. Like, the number of people that were in the room here, from kind of patients to students to academics through to medical professionals, and the people making the decisions within the Irish government and the Irish healthcare system were all in the room, and I think that's a really impressive reflection on how seriously this issue is being taken right now in Ireland. And so I think this event really is a testament to the work of Access to Medicines Ireland, but it's also slightly worryingly a reflection on how serious a problem this is for Ireland today. And so I think the take-home message from this and from events like this has to be the time for action is now, and our political leaders have to step up. So for that reason, it was great to have Michael Harty, the TD and the chair of the Irish Health Committee in the Dáil here, really speaking in support of lots of the proposals that were being made. He's a doctor himself, and he knows that the effect of this problem on his patients. So, that leadership from Michael Harty needs to be reflected and continued by in leadership from the government. This is the third conference that Access to Medicines Ireland have held. I think it's probably the biggest so far. I think with the most high-profile engagement from across government. So it definitely demonstrates that, like, a small group of people with a good idea and a lot of determination have got the ability to influence politics and influence society. So yeah, undoubtedly, I think the work that they've been doing has already had impact, and you can see that. You can see that in the ways that the Irish government is tackling this issue. I think it's great that the Irish government is involved in the Benelux initiative to try and pool the resources with other European countries to get a better price. And I think we will hopefully see over the coming months and years more leadership from Ireland, because it's in a really strategically important position to try and fix this problem.